Take your seats, folks. We'll start on time. We've got a few people on video link as well, or so not video, on Telelink, and I don't know where they're from. I know that is Brittany, but she will make sure that we link up with those people. And that's true, and it's being recorded tonight for all those out there, and they're taking pictures and everything, so you know, you never like to see yourself played back, do you? But anyway, so I'm Greg Stewart, and I'm the President of the Faculty of Public Health Medicine within the college, and we took the opportunity, Lynn Madden and I, the President-elect, because of the presence in Australia of John Hussey and Ruth Hussey, who's been has been in Tasmania talking at the Population Health Congress that just concluded yesterday, and John's here carrying the bags, I think, and he's a very good bag carrier. But John has enormous experience in the United Kingdom, the NHS, with issues that we're hearing a lot more about in the current time within the Australian healthcare setting, things like commissioning and integrated care and how you get better linked up systems, and particularly how general practice in the United Kingdom has developed over the last 15 years, I suppose, from the section. I worked in the National Health Service in the early 80s. From the section of the National Health Service was a bit embattled, a bit kind of forgotten, into really the heart of the system now. It's quite interesting. Now, the commissioning model, the hard commissioning model in the English NHS is not what they do in Scotland or Wales, but nevertheless the idea of general practice being at the heart of health systems, and particularly health systems in relation to people with long-term conditions, chronic diseases, has really become important in the United Kingdom, and a lot of work's been published over the last few years, particularly from the King's Fund and the Nuffield Foundation, about this thing called integrated care. So we're here tonight to talk about integrated care, and because of John's interest, I've asked him to talk about some experiences in the United Kingdom and how these things link together. And we've also got tonight Professor David Tiller, who is a former President of the College of Physicians and a former renal physician, but still currently an emeritus professor, emeritus honorary visiting professor at the Dubbo Clinical School. And David is in Dubbo and Orange often, thinking about medical education, but also thinking about the systems by which we provide care in that kind of setting, because when you're resource restricted, you've got to think about doing things in different ways. So the seminar tonight will go about an hour and a half. It's called The Role of Medical Specialists in Integrated Care. That's my choice of topic because we've had a lot of discussion in Australia around health reform over the last few years about the primary care sector and what happens in hospitals and the introduction of board and activity-based funding systems and how things link up. And rarely do we talk or even recognise the fact that in Australia there's a great cohort of specialists who work in the community and get referrals from general practice and refer back to general practice. Those people often also work in acute hospitals, but whereas in the United Kingdom the specialists work in hospitals and have since the introduction of the National Health Service in 1948, we've got this group of people who are integral, it seems to me, especially in particular specialties, cardiology, endocrinology, general medicine, around this integrated care idea. And so we're going to have a discussion about that. Look, I'm not going to talk for too long, and John said to me when I spoke to him a few weeks ago, I certainly don't want to talk for too long. I'd rather have the discussion, and ditto with David. We've got an hour and a half, and I think we'll finish in that time, and so we'll break it up with discussions in between. So I'm going to start just to give a bit of a flavour of what's happening in my local health district. I'm very much engaged in my local health district with thinking about how you apply integrated care, how you introduce integrated care or enhance integrated care within the setting we have in Australia of state-funded local health districts, by and large running hospital services with a community health arm, and how we link with primary care outside the health system. So, Brittany, if you can put my slides up. Is she there? Hello?
No problem at all.
Oh, there we are. She's there. She's having a cup of tea. And I've just got a half a dozen or so slides just to give a bit of flavour about this. One of the key things was about this bunch of people within the Australia Healthcare setting specialists in the community, and we do forget them. And it's important for us to have a discussion tonight, I think, about how we might remember them a bit better. I'm going to do that by talking about some work we've been doing in southeastern Sydney over the last 12 months or 2 years around trying to say what do we do as a state-funded health service in liaising across the Commonwealth state boundary with general practice, particularly with the Medicare locals when they are in existence, and more recently with the primary health networks. And the point to start is what is integrated care. So I'll put up on the screen here, and I won't read it all out, the definition that New South Wales adopted in about a year ago, a little more than a year ago, when New South Wales put out, you can just see on the right of your picture, the New South Wales Integrated Care Strategy. That went with some additional money that was provided, and I must say and acknowledge, because of the particular interests of the current Minister, Minister Skinner, who's very, very interested in this idea of better joined-up systems and what we do with people with long-term conditions, chronic diseases. So that seems like a pretty robust definition of integrated care, seamless, effective, across mental and physical health, and across settings as well. And so we took that and said, well, what do we do at local level? And ended up developing and just publishing a month or two ago an integrated care strategy and an integrated care action plan. And there's always a danger in bureaucracy, isn't there? You do good strategies and then nothing happens about it. And my experience over the years is the way you get things done is you make people come back every month and you ask them, have you done what you said you'd do last month? And they get so embarrassed that they do it. And that's what the action plan's about. And it consists of a series of things, and it's based on something that John will be familiar with on the right as you're looking, on the left I should say, I'm looking at it as well. The model that's been developed in the English NHS in recent years is the House of Care model, based on work done in Tower Hamlets and other places in the United Kingdom, and I mean essentially based on all the work we know about in relation to chronic diseases, the Wagner model from America, so you know, on the one side of the walls of this house, engaged and inform patients, clients and their carers and families, and on the other wall, effectively multidisciplinary teams, and on a base of what the NHS calls commissioning, but that's not just about purchasing contracts, it's about what are the needs of a population, how do we best meet them, and how do we make our funds flexible so we can meet them. And commissioning will get much more currency in the Australian healthcare setting in the next few years. I know that the central agencies in New South Wales and I think in the Commonwealth are thinking a lot about commissioning models. And on top, the roof is around effectively enablers, and they're IT enablers or they're enablers around how things link up. So that's the House of Care, and those of you who know the Wagner model, and many of you do, will recognise many elements of it are the same. And the second part of it, the second diagram there on your right is a description of personalised care planning. Now, when I first heard this term personalised care planning and started taking notice of it a few years ago, I thought, oh, that's just about the doctor telling the patient here's a care plan. But it's far different from that. It's much more about a mutual discussion between a patient and a doctor. I had the great fortune in just a few months ago, in July, a couple of months ago, to sit in with one of the doctors in Tower Hamlets, Isabel Hodkinson, and when she did a personalised care planning process, an annual process with one of her patients. And it was a completely different clinical encounter from the encounter of I've got a pain in the leg or I've got something wrong with my lip. And in fact, halfway through this encounter, a lovely gentleman with several chronic diseases, he said, oh, would you just mind looking at this thing on my lip? And Isabel said, of course I would. And she said to me afterwards, sometimes quite difficult to separate out that kind of episodic care from the care planning idea. There's a lot of work to be done anyway about getting that idea normalised, socialised I suppose is the right word, because it's not the way that the 10-minute medicine works. So that's the House of Care, and those are the underpinnings of the strategy that we've developed in southeastern Sydney. And we're using this Institute of Healthcare Improvement model called Breakthrough Collaboratives just to try and make change. And there's no way you'll be able to see this, but I've got some copies over, anyone who needs it, over on the left there. And that's a one page on what we're doing in relation to our integrated care strategy. And just to go into it in just slight detail, the first strategy that we've developed, none of these strategies, by the way, are about setting up a clinic for heart failure or setting up a clinic of specialists to look after people with diabetes, right heart failure maybe, left heart failure. We'll have two different clinics for those. They're about system issues, and they're not necessarily issues that the state-funded health system can address. They have to be addressed also within the primary care space. At the core of this is that for people with long-term conditions, chronic diseases, you need to have a primary care base. It's called different things, called the patient-centred medical home, or it's called, you know, integrated care in the community. But we need to be recognising, in my view, that this kind of approach can only take place from a primary care base. And the reason for that is because primary care is the place where whole people are, you know, the person's whole care is considered, not just those parts of the care that constitute specialised care. And that's simply a statement of fact that if a GP refers a person to a cardiologist, the cardiologist is going to do things around the heart. So I won't read all these out, but you can read them yourselves. So, you know, a strategy around motivational interviewing, patient experience and patient activation, a strategy around better data analysis, and risk stratification, absolutely core to thinking about people with chronic diseases. And, you know, the Kaiser Triangle, which you'll all know, and at the top of the triangle, case management and care coordination, the idea of population registers, which we don't have, and the last three around personalised care planning, and then using e-health and using mobile health technologies. And that's what we're planning to do over the next few years. And there's another kind of attempt on the one page to say what we're doing about the diagnostic process that we went through to say what do we need to do around integrated care, and then how we need to do that. And you'll see I've got the House of Care there again, and the IHI kind of tests of change model. It's a bit Sisyphean, isn't it? The ball's going uphill. For those of you who know your Greek mythology, one would hope that the ball doesn't keep sliding down the hill. But this idea about you just keep testing, and on the basis of all these different foundational issues like governance and leadership and culture and quality improvement and partnerships. And I put in an evaluation framework. It's quite hard to evaluate here. The evaluation so far on integrated care models is quite mixed. Sometimes place-specific models are quite successful. Sometimes they're not successful. Sometimes there are fewer hospital admissions and sometimes more. Frankly, I think that using avoidable hospital admissions as our main metric is bad. We shouldn't do that. We should think about much more sophisticated metrics than avoided hospital admissions. In fact, the Connecting Care program in New South Wales, which many of you will know, the evaluation that came out just a few months ago said there was a remarkable improvement in the group who enrolled in Connecting Care after they'd had their 3 or 4 admissions and got enrolled and got their care planning and all the rest of it. Problem was that in the control group there was an even better reduction in admissions to hospital and other things. So we're kind of grappling with that at the moment. And I think that's probably enough from me, just about to set the scene about, you know, integrated care and where we are. And I'll hand over to John now to just talk about, you know, the British experiences and lead to some discussion. Thanks, John. Have you got something here?
I see it's on here. Yeah, so here we go. Okay.
Okay.
Okay, I can see it, but nobody else can. Here we go. Excellent. Thanks a lot, Greg. Thanks very much for the invitation to come and talk to you all. I hope you find it useful. Just to be absolutely crystal clear, my role has been as a frontline GP for the last 30 years in a inner city practice in Liverpool, which is in the northwest of England, and a pretty deprived area in terms of socioeconomic terms. Our patients are likely to die between 5 and 10 years earlier than somewhere down in the south of England. We're not alone in that. The northeast of England has similar problems, and I'm sure my wife would declare the fact that Wales has its own problems as well in terms of those difficulties with mortality and morbidity. And the story here starts around 2002. When there was a major shake-up of the way that the NHS was organised in the UK, and we moved away from what were called health authorities to primary care trusts. Primary care trusts were a way of trying to get clinicians to start thinking about how health services were commissioned right across the board. And this is where we immediately deviate from your situation here in Australia, in that primary care trusts commission both primary care and secondary care, and contributed towards the debate of commissioning of tertiary care and specialist care as well. So, in a sense, the budget was all in one place. But on the other hand, there was historical allocation of those budgets, which was always very difficult to actually move away from. And as it was the case with everybody in the Western world at that stage, it was getting more and more expensive year on year, because the hospital admissions were going up and up, and things like chronic disease parameters were getting worse and worse. And so that was one aspect of the organisational change, but then another little thing happened, in that it was declared that our main hospital in the city centre, we have two large secondary care trusts. This was the larger of the two, the Royal Liverpool Hospital, needed to be rebuilt. It had never, it was interesting because it actually only opened the year that I started in medical school, but it had never actually had a fire certificate. It was built at a time when they used a lot of asbestos in the walls, and the architectural norm at that stage was to put things like the plant for electrics and plumbing inside the pillars that made up the major part of the building, and it was going to take 25 years to do it if we did it piecemeal. So it was decided we needed to rebuild. So of course, all the hospital-based clinicians and managers decided that the hospital for the future needed to be twice the size of the one that it was now, which was going to have to be paid for under PFI arrangements, and therefore probably the local health economy, the local health funding was all going to be directed towards this one hospital. Well, us GPs, the newly fledged commissioners, who didn't know an awful lot about what commissioning meant at that stage, got involved in this program and said, well, does it really, are we really using the hospital as well as we think we are? Because I certainly see a lot of my patients that get admitted through the A&E department that probably never should have been in the A&E department in the first place, and I can't understand why they ended up there, but they stayed there for 6 days, caught a hospital-acquired infection while they were in there, and stayed there longer than you would like. And then, of course, there was the usual jibe between the hospital physicians and the GPs. It's because you GPs don't do things properly, etc., etc. But when you're having those conversations and you get chatting with one another, you actually get to like one another very, very well. You get to know one another. You start to get to know the processes that cause both sides difficulties. And one of the beauties about being involved in the commissioning process at that stage is that you have to start to collect data. So the first thing that we would do would be to say, well, which practices are the patients coming from? Which the initial thing was, well, don't you know? And of course, we didn't have any systems to actually tell us all of those things at that stage. Practice-based computing systems were just largely starting, and of course, we all had different systems that didn't talk to one another. So we started with the data that was available at the hospital to get an understanding about what was happening in our practices. And whilst this talk is supposed to be about what the specialist can do in integrated care, I really do think it's important for everybody to realise that the story has got to start in primary care, in general practice. Because what we found was that whilst there was variation between hospitals across our core cities in terms of outcomes, there was huge variation in terms of what was happening in the general practice setting. And now that we, as leading clinicians in the primary care trust, had a responsible for that commissioning, it really started to behove us to look at not only what we were doing for the individual that was sat in front of us, but also for the population as a whole. And this is where, again, we're in an advantage situation compared with Australia, in that we do have a list-based system. So our general practice at that time were paid on a per-head capitation basis of who was registered with that practice for what were called general medical services. And then there were enhanced services that have been brought in, organised through what was called the Quality and Outcomes Framework, which was about encouraging us to manage chronic diseases better. Interestingly, I've never been able to work out why this was. The Quality and Outcomes Framework, or involvement in it, was actually voluntary. So you didn't have to do it if you didn't want to. If you could survive on what you were paid for on the capitation basis, you could do none of it. But of course, now we were in this position of oversight of the system. That would be pretty embarrassing to actually do that. So we set about saying, well, what needs to happen in the primary care setting, and we started to look about integration of services. Now, I've used this picture for integrated services because it really does feel like it has been a bit of a Monty Python sketch over the last 15, 20. We have pushed that ball up the hill. We have had it roll back over us, and it's been a pretty difficult area. Sometimes we've moved forward large steps in certain areas only to go back in others. But the other thing, of course, is that with regards to the Holy Grail, you've got to know what it looks like. And, of course, it looks like this. I've only been able to I only put that in after we won the last one-day one, so. So, what does integrated care mean? And I think the truth of the matter, and I certainly saw this when I was in Canberra yesterday with Terry Finlay and his team. We're talking about integration. It means different things to different people, and it could be, from a clinician's point of view, that somebody else does the things that they don't want to do. It could be something to do with sharing of monies. It could be sharing of resources. Essentially, you have to know within the geography that you're dealing with what you are truly talking about in terms of integration. And it doesn't need necessarily to be everybody at the same time getting involved in it. It's got to be based around what you're trying to actually achieve. This slide is just one from the King's Fund, which is just showing the whole idea about our current demography of people getting a lot of people over 80 now, multiple morbidity. They don't want to be spending their time in 9 different outpatients a month. They want to have the care brought closer to their home, and they actually want to get on with living their lives and managing the conditions that they actually have and are never going to get rid of, but be treated with some degree of dignity and make the most of what is left for them. That demography is ours. I'm sure that it's exactly the same here in Australia. I think we had a situation around that time where the average age of the admission to the hospital was over 80, something like 83. So we've got to wonder what we're doing to our ageing population in terms of treating them like this. So Liverpool came up with a slightly shorter version of your model of care, and this statement was adopted as to how we would actually organise services right across the whole of North Mersey. They was adopted by all 13 trusts in the area and all general practices, signed to this model of care, that we would in setting up new services, they would always be designed around the patient seeing the right clinician in the right place at the right time. And this was to avoid this situation. There was not a single person that was turning up to this discussion that wasn't working really hard. But they were working really hard doing what they've always done. And as a consequence, you end up with a bike system that looks like this, and you just stay exactly where you are. And clearly, that frustrates everybody. You can see some of them have even gone home on that one. And what we wanted to be was like this. Now, the interesting thing about this picture is that it is about teamwork, but it's often about one person getting over the line as the winner. And we like to think that this is about getting the patient over the line as the winner. So this is all about them achieving the goals which they actually need. And within that group of people, sometimes one person takes the lead for a while and pulls everybody along with them, and other times they actually take a back seat and sit behind and let somebody else take the glory. And this really is what I think we're looking for in the Liverpool area in terms of our integration between services. It's not about who's the best, who's the specialist, or who's the person in control. It is about what is the right thing to actually deliver the system that we require. But this is how we were organised. I'm sure that everybody in this room has seen a slide similar to this. Those labels are the ones that we have in our city at that stage. But there's no doubt that we had so many handoffs. You've referred this patient to me about problems with their eye. It's with the back of the eye. I only deal with the front of the eye. And I'm the occupational therapist for the local authority, not for the health service. So stair lifts are that one, this one. And it was all about different referrals for different people, and nobody necessarily collating this all into one seamless service that the patient would regard as being the NHS. So this is what we're trying to get away from. So then you look at, especially, I think these two people like Engels and Rasputin, but this is the end of a balance, isn't it? A specialist knows more and more about less and less until eventually he knows everything about nothing. Generalist knows less and less about more and more until eventually he knows nothing about everything. Well, I am absolutely certain that we're not at those extremes. But we have to think, have we got the right balance in the system that we're working in? Certainly from our point of view as GPs, what we were finding is that we were unable to get a referral to one individual that actually gave us a direction of travel. We didn't necessarily need them to have every single investigation that every single specialist saw the right thing to do for them, and we certainly didn't want them to have 5 different specialists looking after them while they were in there. And there was nothing more frustrating, for instance, than to send in somebody to be in there who you knew was a maturity onset diabetic, being seen by a surgeon who then gets the diabetologist in to see them when everything was being dealt with perfectly reasonably. And so we started to have these conversations about who should be doing what and what the pathways should be. It's a shame that's a bit small. Okay, if you could just bear with me for 1 second, I'll get that up as a different. Is that better?
Yep. Yeah.
There we go. Okay, so what we were finding that we needed to actually have a way of working, and we had to work together between us, our managers in the PCT, of the local authority, and our hospital colleagues. All very much clinically led, the frontline people being heavily involved in the discussions, and the managers would go away and draw up the framework and the governance and the funding for it. So, starting from the top left, the most important thing, we have to know what we were aiming for. So we started to set some general goals for the city, and it was about reducing unwarranted hospital admissions. It was about reducing first-time referrals that were not necessary. It was about actually reducing the number of follow-ups that were occurring in the hospital setting, and therefore taking up the time of the specialists who were needed to actually deal with the newly presenting problems and start the management plan for them. So there were a number of things we did with this. From the general practice point of view, we completely wrote a new contract for ourselves. As well as having the quality and outcomes framework, we also wrote something about performance that was over and above that particular standard. And we brought in things like access, telephone access and physical access, number of appointments that should be available per 1,000 of the population. We talked about having the control of hypertension and diabetes to nice quality standards rather than the QOF standards, which were a bit of a compromise that were eased up between the Department of Health and the BMA at that stage. But the whole thing was about reducing the number of beds that we were going to need in this new hospital. So at 2002, I think there were 1,300 beds in the Royal Liverpool Hospital, and what we were aiming for was to get down to 970. So we were reducing it by 600 beds is what we were going. So going down to 700. And that was quite a tall undertaking. So we've had a number of different projects that have been involved that we've carried through with this, which I'll be happy to talk to you, but I'll mention a few of them as I've gone along with each of these. The next thing is about IT. We agreed that all of the practices in the city would actually have the same IT system. More than 65% of us had the same system anyway. So the PCT, as part of its commissioning process for primary care, said, right, we'll take over the maintenance of your computers, we will own them, but you're going to have this system. Or it's going to be one that is interoperative with that system. And in terms of working with the hospitals, your computer systems will be interoperative with these practice computers. So by the time you get to now, I can access all of my patients' hospital appointments, all of their hospital results, and vice versa with their consultants in the city. And this was something which we did locally because the national system for one e-record went down the pan somewhat over the last few years. And I think this is also perhaps a lesson for Australia here, is that it's highly unlikely you're going to get a system that will be one for across the whole of Australia. But there is nothing to stop you in a geography that you decide is worthwhile delivering upon to actually do this with just agreement and consensus. The third one was we agreed that there was going to be no handoffs. In other words, if somebody came to you and said, I'd like to see this person, it wasn't going to be a no situation without a discussion about what was best for that individual. So the patient would not be falling between those silos. We agreed to share resources. We have one of the problems relating to the hospital admissions was getting them out the back door. So discharge planning started to have a multidisciplinary process to it, which started as soon as they arrived, with social workers based in the hospital setting and community nursing services working with the social services to actually pull them out the back door. And we are starting to put the shared resource between the health and the local authority into what's called a Section 75 agreement to actually oversee that. There's been a large one practice-based, they have somewhere in the 25,000 patients, policy of having these co-located over the last year or two, and that's now coming to fruition, and we're now setting up a process to actually roll that out right across the city. Shared governance is important because otherwise people hide behind, I can't do that because my trust won't allow me. And the most important thing is to work towards agreed outcomes. If you haven't got outcomes that you're aiming for, you can't possibly measure whether you've succeeded. The bottom three, I think, are the three most important aspects of making integrated care work. The first one is that you have to have effective leadership. And I think when you're trying to change a system which is so engrossed in medical and clinical work, those leaders have got to be clinical. They've got to be people that the frontline people recognise, that understand their jobs. But on the other hand, we have to recognise that those leaders have become leaders because of who they were as their individual clinical responsibilities. And we have to respect that and not put them in a position where they're actually putting their clinical work at risk because they're away doing something else. So backfill has got to be appropriate. They mustn't lose out in terms of their targeted resources. And essentially, we have to nurture those leaders, giving them various courses to go on in terms of learning the different processes that they can actually, styles that they can use in different settings. The next one, I think, is a really hard one, and I think it's one that always, and that's effective followership, because we are like cats, aren't we, clinicians? We are very, very difficult to herd, and we've always got a fantastically thought out, erudite reason as to why we shouldn't follow. But it's really very rare, if you've got more than one way of skinning a problem, that the one is going to be that much bigger than the other. So why do we get so wound up about just picking on one and saying, okay, we'll go? We've actually only got through on this one by just keeping at it, and it's just a matter of listening, reflecting back, providing evidence about what works, and constantly hammering at it in order for that to work. And that's where the effective communication comes in. It's got to be all different types, depending on the nature of what people actually want to do, how they like to get their communication. So it's emails, it's letters, it's face-to-face, it's pressing the flesh, it's all of those things need to happen. And those are the things that we found work. So I'm going to get out of this one now and go back into my other one. And these are the sort of areas that we've started to look at. And there won't be any surprises here. They're all based around the chronic diseases that make a big difference to our figures and our patients. But mostly they're ones where the clinicians on both the GP side and the hospital side decided that they did want to do something different. So heart failure is one that we have a consultant-led but GP-delivered offered heart failure service with specialist nurses, and also fixed into a telehealth program, which is around the patient being linked into an iPad, where they send data through on a daily basis about what their blood pressure is, what their SATs are, what their weight is, and then if they're all put together into a risk strategy, a risk factorization, and if they're going in the wrong direction, they either get a call or a visit to adjust their regimen, and that has resulted in significant reductions in the heart failure admissions, kept people at home, kept people with their families. Diabetes, there is a citywide diabetic pathway from initial diagnosis through to need for tertiary referral that has been agreed with all the diabetologists and also all of the practices, using some specialist nurses in the community. But effectively, it is about 90% of it being dealt with in the general practice setting, including things like insulin conversion and so forth. But we're on a regular basis with the consultants doing outreach clinics in the new facilities that we've built in the community to house the aggregation of the general practices. COPD. This has been done in a number of different ways. Sometimes it's been consultant-led, other times it's been mostly GP and nurse clinician-led, but effectively about using the practice's data to identify those people who have got COPD, making absolutely certain they've all been referred if they're willing for pulmonary rehabilitation, making sure their inhaler therapies are optimized. So we have medicines management team involved in that. We have the practice nurses, the GPs, and for those cases that are brittle or requiring admission, we have a consultant who's working with us out in the community dealing with that. The other aspect is there is an emergency response team so that the patient can actually access that team if their parameters are not actually working in the way that they would normally expect them to. This is more to remind us. We have an intravenous antibiotic program, which has been worked with the local community microbiologist, who's helped us write the pathway for this. And this is for people with cellulitis or for pneumonias that have not responded immediately to oral antibiotics and who aren't actually their SATs levels are such that they can still be kept in the community. And these can be accessed 7 days a week, and also reduced the admissions from this, which is a very common one for people going in and staying in for several days. Also use this team in the palliative care setting for patients who become very anemic and require transfusion. So we have home transfusion or transfusion, if you don't want it in your own home, in your local primary care setting. But effectively means that you don't get into hospital and get all the various infections that go with that. This one's also to remind me about a DVT program. So DVTs, particularly lower leg DVTs, they are assessed, Dopplered in the community. D-dimer got within an hour with a near patient testing. If they're not got a DVT, then they are sent out immediately. If they have, they immediately go on to Fragmin, and then the community anticoagulant team actually get their warfarin into them. So they're not sat in hospitals waiting for all of those parameters to come to the fruition. Essentially, this is what we're aiming for. An elderly person who can spend their time at home with their family, not being admitted from the setting that they're that they're used to, and not put it at risk of the dangers that are evidently there in acute hospital settings now. Big thing with regards to this, and this is for the GPs, is that it is about us working a little less isolated. It's about us sharing our data. It's about us sharing our outcomes with our colleagues. It's about us listening to our colleagues about what works and what doesn't work, and it's about having those conversations with our secondary care colleagues in terms of how we can actually do these things better. There's no doubt that if we can actually implement in the community all the things that we know that work, we'd actually have a far healthier population than we have at the moment. And I think that's the part that we need in places like Liverpool, where the population outcomes are the ones that are actually leaving us at the bottom of the heap. And we need to actually think about the individual all the time that's opposite us, but we've got to think about them in terms of a population strategy in primary care as well. So my summary would be, don't worry too much about your organisational structures if you've got the will within the clinicians to actually do something different. But they are undoubtedly they are barriers. The professional development as specialists, I think, is also another one to think about. Have we over specialised ourselves in the hospital setting? Very rarely do you see every single one of your cities specialists getting the Nobel Prize or whatever or the research prize on a national basis. Yeah, the colleges are driving them to actually go along a research base all the time, when actually delivery on a population basis for their area may actually produce more good from them as an individual than trying to look at serum rhubarb or whatever in different settings. Indemnity has been an issue in various places. Whose is the patient at any one time? And I think conversations with defence organisations about how the pathway can actually be delivered safely with indemnity being covered. People need to feel as though they're acting in a safe manner. The training goes with the professional development. Our students are not trained to think about population health very much. All of their training is around looking after the individual and the evidence base around that. And I do believe that's got to change. And the money side of things, you're going to have your own issues around the way that you organise your money here in Australia. All I can say is that it can be done to via monies between different organisations if there is a will in the local area to actually do things differently. So the summary for us is aiming for the patient to be at the centre of what we're doing, rather than being the pawn that's passed around. Getting the care closer to home, co-located where possible, avoiding handoffs, communication being absolutely the key. And the other thing that I would really advocate, which will give you the spur for your practices and for your hospital base, is getting that access to the single record, which will give you your evidence. Thank you.
Stay there. John, stay there. So the plan was some clarifying questions now, if there are any. We'll have a discussion at the end. But before I call on David, any sort of things that will help us in terms of the discussion later? I've got one which I'll ask anyone from the audience. And we'll probably have to repeat it for those online, John. So my question's about shared governance. Nice little box up there. But what did that mean in practice?
In practice, that was with the local authority. So the Section 75 agreement was based around there where the money was put in, and it was where we had a specific area where it could be spent on. That had to go through the Health and Wellbeing Board and through the boards of both the local authority and the PCT. And the other thing, in terms of the various pathways that we wrote up with the hospital consultants, that was about actually getting that agreed throughout all of their directorates and through their quality teams.
Okay. Anything else? I'll call on David. Okay. We can swap over now. So I'm aware of the fact that if I speak here, then those online can hear. So I'll do that. You can take a seat. And this idea around implementation science, it's underdone, isn't it, in the practicalities of what we do, those of us who work in the system. You know, how do we take models and implement them? Because, as I've said over many years, planning's easy and implementation is hard. And, you know, the best model in the world can fail because of whatever reason, around culture or around lack of resources or around lack of commitment. The King's Fund has published a fair bit on this, a lovely article a year or two ago called Making Integrated Care Happen at Scale and Pace. 17 things to think about, and they were things like leadership, partnerships, information systems, knowing what you're doing, having clear objectives. And when I read the paper, I thought, how does that help me on Monday morning when I've got to go to work and do things? So it's, you know, it's really interesting to hear how it actually happened on the ground in, you know, an area of the United Kingdom that, you know, had significant disadvantage. Although, I suppose since Liverpool was made the European City of Culture, it's gone beyond the, you know, the sort of, you know, the worst place to live in the United Kingdom, which it must have been at some stage, I suppose. Was it when you were there, Lynn? I don't know. Never. There we are. So that's right, always the best place to live. As I said before, Professor David Tiller is a former president of the College of Physicians and a renal physician, and for a long time the head of renal medicine at Royal Prince Alfred Hospital, where he was around for most of the period where the renal department saw enormous growth in what it was doing around dialysis and around treatment and all the rest of it. I first met David when I was a young medical administrator, and I had discovered that there was another fellow in the renal department I'd never heard of. His name was Fippard. He did research, full-time research. And I said to David, and I was then the medical administrator responsible for the medicine division, so I had to think about efficiencies and so on. So how come I'm paying for a bloke who's doing full-time research? David said, it's really simple, Greg. Don't you know there are 4 of us in the department, me, Jeff Duggan and 2 others, and 25% of our time we are allowed to spend on research. So we took our 25%, and that made 100%. We employed Dr. Fippard to do it for us. And I thought, how could I possibly respond to that? I've been completely aced by a man who knew much more about administration and management than I did. So David's going to talk. You remember that story? I do. There we are. I tell it often. Going to talk about some experiences that he's had in the last few years, not in renal medicine, but more in regional care and in the provision of this kind of care we're talking about in a regional setting because of his role, as I've said before, in the rural clinical school. Over to you, David.
Thank you.
I'll try and get this up, which I can do.
So I haven't spoken to the college for a while. It is an Australasian college, of course.
It is Australasian.
The Kiwi and the Emu there. And we talked to the Kiwis about changing that to Australia and New Zealand. They didn't want to. It's a long discussion about it. I mean, that's what committees are for, isn't it? You have long discussions about critical issues, about names of things.
Absolutely.
Okay.
There you go.
Yes, okay. So
Brittany will get that up.
I just had the feeling that there'd be a mention about the cricket. So this is about the delivery of care. I can see the slide there, but you can't yet. Do I do something here, or does it just happen magically? It'll happen magically. Okay, good. And the reason that I'm talking here is because Dr. Stewart happened to be in London at the time of the Lord's test. Now, I know there was an important public health activity on at the time, but he just happened to get some tickets to the test for 2 days. I mean, the rest of us. So there. Now, John, you may not know that man, but it's 100 years since he died. That's Victor Trumper, and there are a group of Australians who are obsessed by this man and what he did. And he was an extraordinary person, and I was asked to talk about him, not because I knew anything about cricket, but because he died of Bright's disease. And Richard Bright, you all know, who was at Guy's Hospital with Addison and with Hodgkin, extraordinary time in the development of internal medicine. So the delivery of care, we haven't talked about this at all, but my conclusions are very similar to what you've said, John. But what I will do is talk a little bit about the problem of distance and time and space. And I can change this by...
Just press the down arrow.
Down arrow. Okay, now it is of interest that this appeared in the New England Journal of Medicine about 4 weeks ago from Jane Hall, that many of you will know, a health economist, who said Australia has a very good health system. And I cheered. I was on my own on my computer at the time. Someone heard me cheering and wondered what was going on. We are very critical of what we do, and I thought this was it was the first article in the New England Journal on the 6th of August, and it's worth reading, I think. And she argues the point that we have a pretty good system and it works pretty well. Life expectancy is good. The median cost of looking after us all is about right. And we've changed from what were called Medicare locals, which was an attempt to do what you were describing as to how we could concentrate the care in groups, and they're now called primary health networks, and I suspect you guys will change it again and change it into some other name. We'll have groups of practices that will look to looking after the people in their area. So the issue is about care, and you mentioned care, and I think that's crucial, and I think that's what I talk to the students about, is that how do we ensure that we're delivering the appropriate care? That's Karen von Blixen, who's really got absolutely nothing to do with this at all. She wrote Out of Africa, of course, as you know. But she did say, what else is man but a minutely set machine to turn with infinite artfulness the red wine of Shiraz into urine? And I thought that's a wonderful quote, and it's one of the reasons that I got interested in kidneys. So the infinite artfulness, I'm not going to talk about. I could, but I won't. And so the issue is, how do we deliver care in the setting that I see in Western New South Wales? What it is about is that last picture that you put up of they always have lovely pictures of old people looking terribly happy, being looked after by someone who also looks terribly happy and seems to, in a lovely setting. And it's not all like that. We all know it's not like that, but that's what we aim for, and I think that's appropriate, and it's the question we should always ask. What effect what we're doing or what we plan has on care. Now this is about us, New South Wales. This is just one of our 6 states and things. 800,000 square kilometres, population 7.5 million. United Kingdom about a quarter of that, with 65 million people. So we're spread very thin, and that affects care. And that's my point that I wanted to raise about how do we do that, particularly using your model of things. So specialist medical services. We know, because largely the public health people have documented what our demography is like and what people have, how much heart disease, how much cancer, respiratory disease, trauma, all of those things. And so we know exactly what it's sort of like in a broad sweep. What we struggle with is how do we deal with the individual. And it's because they're spread. And that where you might have 10,000 people, we might have one. And that really does create enormous problems for us. So what sort of people do we have? Well, we're going to have VMOs, visiting medical officers, staff specialists, fully salaried, honorary medical officers almost disappeared, although I sit on an appointments advisory committee and there are more of them appearing again. I think it's just to get a foot in the door. I'm not sure that they're... and then should they be part-time or full-time? One of the things that's happened in our change is the number of women in practice. When I graduated, about 8 or 9%. Now it's about 50%. And the ladies generally only work, this is a generalisation, about half to three-quarter time, because they do the other things that we can't do, and that is have babies and look after them and do all of those things. So there are a lot of part-time people in the program. This is John Sands. Don't think any of you will know John Sands. Oh, so of course, do know John Sands. John Sands was my hero, I guess, and he was a general physician at Prince Alfred when I was a student, an intern, a resident. His rooms were at the back of this building in Macquarie Street, and he used to do rooms in the morning. He'd walk up and have lunch at the Australian Club. We went from there up to, and then he went up to Prince Alfred and we did rounds. He did that Monday, Wednesday and Friday. On every alternate Wednesday morning he wasn't available because he was on the board of the Bank of New South Wales, which then became Westpac, etc. And and he was a terrific physician, and he was a generalist. But he and a guy called Ralph Reeder, who was the first director of the National Heart Foundation, decided that they should have a group interested in fluid and electrolytes. So he was the sort of the genesis of renal issues. But when he was there, there were 6 general medical units, 6 general surgical units, and there was a sort of a funny person over in the Page Chest Pavilion, which had been built for tuberculosis, who was interested in cardiology, and he became the first full-time cardiologist, and I'm talking late 60s. Well, most of you hadn't even been born at that point in time. So fantastic, general physician. And I put him up particularly because I will be critical of general physicians. But this guy was fantastic. He looked at patients, he talked to them, he knew them, he didn't know what their incomes were or what they did. Fantastic guy. Now this is the area that I look at. This is not a map that you'll be familiar with, but at the bottom, I think, is there a pointer on this? Ah, there is, look. Oberon to Gaduga. I bet I'm the only person that's ever been to Gaduga. Oh no, look, there are Gaduga people everywhere. Okay. You can blink and miss Gaduga, I might say, etc. But that's the same distance from Oberon, and that's our local health district. And it's in that area, we've got about 250 family practitioners and about 250,000 people. So if you drove from Oberon to Gaduga, you'd pass about 250,000. You drove from London to Edinburgh, you'd pass, what, 50 million? Wow. That makes an incredible difference to the delivery of care and how we manage it. And then you've got these characters. Okay. And I've got a bigger picture of that Indigenous person with a tie and a watch. That's unusual. But nevertheless, they look sort of grumpy, don't they? There's a bigger one coming up. That's Broken Hill. You can tell it's Broken Hill by the slag heap at the back. Okay, that's, 1,200 kilometres from Sydney? 800 from Dubbo. Dubbo's 400 from Sydney. The distances are enormous, and so you can't see it, but at the top here there's a flag, and it's the CFMEU's flag. I think that, anyway, that's Lismore. That's where our students go to these, and that's green, isn't it? It's lovely. They all love going there because it's only 40 minutes to the beach. Yes. And then there's the technology. And you're familiar with the technology, and I saw there are at least 2 or 3 people who were using including myself, using their phones while you were talking, John. I suspect copying down what you said rather than planning their evening activities. And we have to embrace this technology. It's critical that we use it. It's being used between emergency departments, scattered across the state. It's really difficult to look at skin lesions and colour, but it's getting better, and it will get better, and it's one of the solutions that I think we have to keep reminding ourselves of, that the technology will allow people at home can pull this thing out of their pocket and talk to their local doctor or to the person they talk to or whoever's their physician assistant or whoever it is. So we have to think about technology. That's going to be crucial. And it was interesting. I don't know whether I know that you're all Star Wars fans. But this guy comes out, the obstetrician, he's a nice looking sort of person, and he said, we're losing her, and we don't know why. And I thought, well, that's right, there will always be doubt about whoever's looking after the patient and the patient. And so we have to work at that, and that's always the question that we need to. And then I thought, this is my planning committee slide, so I think there always needs to be one of those, and the sort of results are sort of different, aren't they? And you can make that up, you can use that for whatever you like, but my observations are that everyone is concerned with the things you're concerned about, that it's not being ignored, that there is a shortage of money, but everyone wants it to work better. And so I'm reassured that even though Heath Robinson designed this particular committee structure, that it's likely to work. Now, what about these guys? This is the patients. This is cattle sales. Indigenous gentleman here. As I said, he had a watch and a tie, which is unusual, but they are cattle sales, and it's of a different era. And there the ladies up the back with pearls, so that sort of dates them, I guess, as probably 1960s or something or other. But these are the people. No one in this room has hands like that. They're workers' hands. And so people have to realise that, have to understand that the last thing that any of these people want to do is to move. They don't want to go from Winaring way up in the northwest to even to Dubbo. You know, that's the city. They certainly don't want to come to Sydney. So that's a challenge for us. The Indigenous patient, of course, won't move unless he can bring his auntie or his husband or his wife or whoever the particular person that's involved in their care. And as you move to the north and to the west of that area, the number of Indigenous patients increases to something like 20-25% of the total population. And it does create real problems. And so it needs a particular person or group of people to look after them. Look, I just thought I'd put this picture of a ward in the 1970s. I think it's not that long ago. I think there are a number of things that I'd like to notice. There's one registered nurse and a group of trainee nurses, and there are 22 beds in there. Trust me, I counted them. But look at this. There's a guy, and they've all been done up for the photograph. They've all got proper bed corners and that sort of stuff. No air conditioning, 22-foot ceilings, heating in the centre of the ward, wooden floors. But this guy's reading the Sydney Morning Herald. I mean, there's no one in hospital now who's well enough to do that, as they all get sent home before they can even pick the Herald up, much less read it. So things have changed, and it's your point about the number of beds. It's because things are so expensive, and the hospital and the home and those sorts of things that we've been talking about. So in about the late 1970s, we changed from being 6 general medical units at the hospital and 6 general surgical units. There were other obstetrics, and all of those things were separate. And we changed to this sort of thing over about 7 or 8 years. Took time to change, and people moved around, and that's the way it sits now. And we've been open to a lot of criticism because departments of health particularly see this person as the solution. That is, we get a generalist, we won't have to get a cardiologist or an oncologist or whatnot. My argument is that if you're in Burke and you get crushing retrosternal chest pain, you have to design care for that that's the same as if you're in Newtown, which is a kilometre from Royal Prince Alfred, to get that sort of care. So how do you design that sort of solution? Or the lady with the breast lump, okay? How do you do that? And you can design, and you can go through all of the things that you can think of. How do we do that? we're never going to have, there's never going to be a neurosurgeon in Cobar, but there are minds there and people get subdurals, and in the past people have opened people's heads up at in the local hospital, which must have been scary to say the least. So it's never going to happen because of population, or never's a long day. It might happen when some of the younger people here are very old, but I doubt it. We're never going to have that ability. So we have to think, how do we get people to the carer? Okay. Yeah. And so these are physician's assistants. We don't have physician's assistants. I met an American physician's assistant about 3 months ago now, and she worked in a family practice, and her particular involvement was in abdominal pain and shortness of breath. That's what she did. She'd been trained in that. She'd done nursing. She then went to a particular program and you could book and see her. She could write prescriptions, and if she stepped outside those particular areas, she just referred them on to one of the other people in the practice. And talking to the doctors, they thought it was fantastic. Our doctors largely have poo-pooed the idea and said they're incompetent, impossible, and we're so much better. And I think that's just wrong. But I don't think we can change the Australian psyche, and I wouldn't bother. Physician's assistants, well, this is all the people in the renal unit, sorry. These are all the people, anyway, I don't know, we're trying to go back. I'm trying to go back.
That's it.
I'll go forward instead, eh?
Yeah.
Okay, so these are the people in our renal unit, and you'll notice all these folk, and they were fantastic. And we had people scattered throughout this northwestern part of New South Wales, because that was sort of our axis, and it couldn't have happened without them. So, and they never rang me. They rang the nurses or the technical staff. We had technicians. That's the future Chief Medical Officer of Australia there in his younger days. Do you recognise? No. You didn't recognise Professor Horvath? There he is, there. Anyway, and the nurses were fantastic. So there are groups of people, and they all had first name terms because we didn't have a lot of patients. So our dialysis transplant group was small. We knew them. We knew their husbands, wives, etc., etc. So that's what it is. I mean, that's just a big hospital. I think they're worth keeping because they can do all sorts of things. But I think this is the general practitioner is the bedrock. They're the people that are going to sort this, that are going to direct people in the right direction, going to sort out your queue, so they'll say, no, don't worry about that, don't worry about that, but I will call so-and-so, and using the technology. And so that's my message. General practitioner is the bedrock, the delivery of care in rural and remote Australia, and constantly ask as we change things in all our committees, whatever I'm advocating, will that improve care? Thank you, Greg. Thanks.
Thank you, David. So that's a tremendous mix of perspectives. But in the end, it is this issue, isn't it, around what models of care do we use? How do we better provide care, especially for people with chronic diseases? Now I'm going to throw it open. We've got some time to have a discussion. Peter?
Can I just ask a matter of clarification of David?
Yeah. I'll repeat the question now.
Maybe I'll pick you up for a second, but I can't imagine when you were speaking, David. But the issue of general physician, I wasn't quite sure what you were concluding there. Were you concluding that we
look, I think John's statement about the general physician, unfortunately, is true. I mean, the problem that we had in the big hospital was that if you'd been called a general physician, you had an obligation to work it out, And so that delayed, if I was on another floor and they had someone with kidney problems, why didn't they just bring me and say, I've got someone, I can solve it in 10 minutes. But they spent 2 weeks working it out.
But do you think there's still a role for clinicians out in the country?
No, I don't. No, that just diminishes the level of care. I think it's wasting money. look at the way you deliver care.
Right.
But you, I mean, you wouldn't go to a general physician if you've got crushing representatives, would you?
No.
No. None of the gentlemen would go to a general surgeon to have their prostate out, right? And the ladies who had breast lumps would want to see a breast physician.
No, that's fine.
Absolutely. No, I think it's a waste of space, but the college is accessible.
Okay.
They are. They're very keen to press it. I'm sure they don't. I'm going to ask Charlotte to make a comment, because perhaps where you're going, David, is that the generalist is the general practitioner.
Well, exactly. But you see, they're used to sorting it. They know the patient, they know the family, they know what's going on, and they can make a decision about it.
Thank you for being such a good advocate for general practice. As a GP, I can't but agree with what's being said, and I think the solution is with the GP. And I would ask that in the solution for integrated care, that the GP be with the patient at the centre of the solution, and not be the person told what to do in the integrated care solution. Because I think that's setting up for failure. And my big beef with New South Wales Health is that they are so hospital-centric. And I'm not wanting to be insulting in any way of you as a population health person there, but I think they're so hospital-centric that they're working really hard about this whole integrated care with a really good reason, but they're just not talking to the GPs in a way that's actually, I think, the best solution for finding pathways to care. And it's certainly in my LHD, we've had this, I think what has been revolutionary has been the called pathway process, where I don't care what you do, whether it's health pathways, map of medicine, or whatever solution you use, but the concept of the GPs being at the what do we need to do to solve how we access care for these problems, and then going to the hospital and sorting out a clinical redesign to make sure it works for everybody has been fantastic. Again, it's about the relationships. You talked about that the joy of the relationships where it worked was actually, you know, the GPs were beefing about the hospital and the hospital were beefing about the GPs. You get in the same room and you forget about the beefing. You realise you've got the same problem, and the problem is about trying to make sure the patient gets the right care by the right person at the right time. And we can do that together.
I think that's absolutely right, and I agree with you that you want to have, for the things that need specialists, you want to have a proper specialist. But the issue, I think, is that we tend to use the specialists too early, and that's what causes the variation in practice activity, general practitioner activity. And it's to do with the level of uncertainty that an individual can actually go through. And whilst you're talking from a physician point of view, we also have to deal with obstetrics and gynecology, paediatrics, and surgery. And I just think there is a real role for a general physician that actually spans that gap between the patient advocate in the general practitioner and the specialist for certain areas, whether it be related to women's health, whether it be related to paediatrics, or we cannot. Whilst I don't believe that we know everything about nothing or nothing about anything, we certainly don't. We're along that line of the scale where we do need some support before we need the neurosurgeon. And even in a urban environment like we have in the UK, I do think there is a role for that generalist.
And I agree with you too, in terms of, I think sometimes that problem solving, one of the interesting things I was looking at is that they were saying that 8% of a GP's patients are the difficult to solve problem. But they may not, but they're not necessary, so they're not someone that I can say I need to send to a cardiologist, I need to send to a whatever. They're that, oh my goodness, I don't know where I'm going with this. I know there's something, and they're the rare things. And that's where sometimes having a conversation who is as good as we are at looking generally, or even just doing a story. One of my favourite books is by an American physician who has a strong concept of that you can solve 90% of the problem by sitting down and taking a history from it. And I think that that's the joy often of someone who I see more as a general physician who, and I like the rheumatologists, and I've got certain specialists that I know will sit down and just spend a huge amount of time taking really good history with maybe more expertise than I can add. That then helps start making problems.
Don't the geriatricians claim that mantle to some extent, Charlotte? That, you know, the geriatricians say, well, we kind of do that. The rheumatologists do to a certain extent too. I was talking to one the other day.
And the geriatrics have taken over the general role, etc., because they often elderly, aren't they? But people change the rules about how old you're going to be before you see a geriatrician, don't they? Because the jury's complaining, I said, it used to be 65, now it's, I don't know, 800. But yeah, they're good at it. And they're generalists, but they're looking at the patient, which is the critical.
Yeah, taking
the history.
Yeah. Not firing the gun.
Other questions or comments from the audience? Left? Anyone? Lynn and then Stephen. Lynn?
So, John, I'm interested in the rebuild of Liverpool Hospital. So, a new sort of structure for a hospital as well, a new type of hospital. I mean, what happened in the end for that focus?
The main difference in terms of the structure of it is that it's single patient rooms, no wards. That's the beginning. But they still designed it, with the A&E department being next to the radiology department, which is next to the cardiology department, next to the respiratory department. There has been a discussion within the health ethical program about whether we should be building a hospital without outpatients. To take into account the use of technology in terms of mobile phones, etc., and also the fact that we've actually now got those buildings out in community which is designed for outreach where face-to-face is required. So, but we haven't quite agreed to that as yet.
We rebuilt a Liverpool hospital in Sydney about the same period that you were rebuilding Liverpool Hospital in the United Kingdom. It went about doubled its bed base, I think. But there was a lot of population growth out there. Stephen Connerty, and then over here.
Yeah, I suppose my question is for John, but it could also probably be answered by others in the audience, and it's really about, it doesn't matter where the power lies in the system, because, I mean, I worked in the NHS for quite a while, including a primary care trust, and I thought the fact that they were the commissioners, that they held the budget, that they were able to bring people to the table, and they were able to sort of sort through problems in the system, I think was just quite different from where the power really lies in the system here. And so does that, my question is generally, does that really matter? Or do you think that with innovation, like we talked about health pathways, that thing has this or, you know, can we get to that same place?
Fundamental question about how the system. What do you think, John? I mean, you can compare what happened after 2002 with before. That wouldn't be a bad way to look at it in the NHS.
I think the most useful thing about GPs getting involved in the commissioning side is that it actually held a huge mirror to us about the variation that we have between ourselves. And largely as a group of clinicians, we're doing everything we could for the individual in front of us, and then when we were no longer able to deal with it, there was something else that somebody was actually setting up to actually organise that care. That was what the general view was. Whereas when we became responsible for how that money was spent, or partially responsible, we weren't not totally responsible for it. It really did make us think about what we were doing. And although there's variation between hospitals, there's much greater variation between individual practices. And we started to realise how isolated we were. And so now, I don't think it makes any difference. I think we like to share that responsibility with our consultant colleagues and hospital-based colleagues and community-based clinicians in actually looking at the pathways that are required. And in fact, we now have in CCG, we have secondary care consultants on the boards of those to actually give us that perspective, because I think that the process that we've gone through since 2002 has shown that it is that dialogue and that constant challenge with one another that actually makes a difference.
Question over there?
Yeah, question for John. Thank you for your talk. It's very interesting. I just wanted to know, presumably you saved a lot of money by closing 600 beds. Did you have to hand the money back, or did you?
Absolutely not.
Were you given the opportunity to use that money for more innovative services?
We managed to build over that period of time 12 neighbourhood treatment centres in the community. We've also been able to fund the various innovations we need in the hospital setting in terms of new kits, etc. And we've also in the process of moving the cancer centre in next to that hospital. We've kept A&E attendances flat over a period of 6 years, which, despite an increase in the number of people in the population with population growth and asylum seekers, etc., and we've kept to budget. But no, we don't give the money back. That whole point is that we can actually do it for the next iteration of changes that we require. I have to say, this is not just GPs that are making these decisions. We have management support, we have technological support, etc. It's not just to reassure the hospital-based people that the prisoners have not been given the
Steve's question's important here about how the system is structured. But best to take the view you've taken, John, and I've taken in relation to the work we're doing. Ignore the organisational structures, say what the system should look like, and then try and find ways around systems that have some dysfunction in them. But it's not as if, we shouldn't think that the English NHS is some kind of nirvana. The commissioning that John talks about is commissioning of secondary services. So, general hospitals. Specialised commissioning is done from NHS England, and primary care commissioning is done from NHS England as well.
Well, not now.
And changing now. But it's interesting, isn't it, that the primary care trust or the clinical commissioning primary care trust had a lot of money to commission hospital services, but they didn't actually have as much influence over how primary care services were provided. The kind of things you've talked about, John, I think were because of cooperation locally and about saying to. So sometimes the financial stick's important, and sometimes it's about cooperation. Yeah.
I do think it's interesting though that part of the reason why when CCGs were formed, they took primary care commissioning away from them was because there was seen to be a concern about vested interests and a challenge around the way that they spent the money. But after 3 or 4 years of them, they're actually recognising that they are behaving responsibly and actually are now giving them primary care, the chance to commission primary care as well.
Question or comment?
Yeah, so just a question for John and just generally. I know Jeremy has been operating backlash over these divisions in NHS in saving and serving its service. And how important do you think that is in the provision of integrated care?
I think it's really important. I certainly think that primary community care should be 7 day. I think there's a recruitment issue that runs with that, but I do think that we should be providing in the community where people initially get ill exactly the same care on a Saturday and Sunday as they're getting the rest of the week. I'm not so convinced that the whole of the hospital needs to be working exactly the same on 7 days a week. And in fact, there's no doubt that there are problems around covering rotas and stuff like that in the hospital setting. But what we're also finding is that with the NHS England review of their specialist services, we've probably got too many. I mean, you were making the point about geography, David. We've probably got 4 cardiology departments, all singing, all dancing in Liverpool alone. It only covers an area, even if you take Merseyside of 1.5 million. And they can't run a 7-day rota in each of them, but they can sure as hell run a 7-day rota in one of them. So they're actually talking now about merging those specialist areas and reducing the number of sites that it goes from. You may have read about the stroke test changes in London, where none of them were actually achieving the standards that were advocated by NICE. So they got together and they reduced. How many did they reduce it by? It's gone down from nearly 20 sites that were saying that they were doing stroke services in London down to about 5 or something like that. And the standards have gone up completely. They've got it 7 days a week. People are spending more than 95% of their time in a proper stroke bed. And it's about looking at the outcomes and looking at what you're delivering at the moment. And that's the part which I think has made the biggest difference to all of this. Is all of us understanding the outcomes that we're actually delivering.
Peter?
Well, I was just going to draw attention to the major difference between Australia and Britain, because private care. I don't know what the percentage of care in Britain is private these days, but 45% of the Australian population hold private health insurance. Private hospitals provide lots of free surgical services across Australia. I realise that primary care is not for the most part privately provided, although there are moves for private health insurance companies to be involved to some extent in funding some primary care services. So, I wonder whether that makes any difference whatsoever. Maybe it doesn't, but I'm not sure. It seems to complicate things here in terms of integration of care.
Yeah, well, I'll make a comment because of the question I raised at the start. Regardless of the fact that a universal health insurer outside hospitals, we're all covered by Medicare, we're all private patients outside hospitals. Nothing irritates me more than to hear people talk about public patients and private patients in a setting where we're all private patients. We're all covered. We might as well have paid insurance because that's what Medicare is about. But because of history as much as because of that funding source, there are, as I said earlier, medical specialists in the community, and by and large medical specialists are hospital-based in the United Kingdom. Although I think there's a big push for them to go outside and get into you talked about it yourself, John. So the question I asked, I'm interested in comments, maybe from you, David, or Sue, about how do we engage with those people? I've had, when in the discussions I've had in the last few years around integrated care and our primary care base and around how we have to have specialists can do specialised things, but they can't do the things that can be done in primary care. And I'm pressing that argument pretty hard, Charlotte, but I often get resistance from specialists who have a kind of inherent conservatism, but an inherent suspicion of general practice. Quite explicit things. There's no way, diabetes doctor, there's no way a general practitioner could possibly, look after this person who's on 3 or 4 different oral medications. I think to myself, I don't know why you'd put anyone with diabetes on 3 or 4 different oral medications, but I don't claim to be an endocrinologist. So this idea around how we engage with that group of people is really important. I don't know the answer to this, but I think it's really critical. There are lots and lots of private endocrinologists in the community who get referrals from general practice and make a good living out of seeing people with diabetes and other endocrinological conditions. And I think things are changing in the United Kingdom around that. By and large, diabetes is managed, as you've said here today, John, in primary care.
Do you know what the outcomes are from those studies?
No, we don't really know outcomes because we don't collect the information so well. Some general practice collect information, and I don't think it's as comprehensive as because of the quality outcomes framework and so on. But we've been asking some of our general practices in my local health district, what can you tell us around the quality of care around people with diabetes? And quite a lot of them can give quite good information at a personal basis about hemoglobin A1C or any other measure you like. Charlotte?
I actually think it's very good in primary care. there was a really good study done by Professor Claire Jackson in Brisbane doing an integrated care type program where you could consult the specialist if you need to. The cost per patient was a tenth of what it cost to manage them through the diabetes clinic, and the outcomes were significantly better. There's no doubt an engaged GP can manage diabetes much better than through a specialised clinic, and it's about the whole monitor model of knowing the patient.
Was an important word in that.
Yeah, but I think the other thing is that both the specialist and the GP are nervous, and probably the patient as well. When with our transplant folk, from all over the state, we sent them back, but we spent a lot of time talking to the local doctor, making sure that they understood they could pick up the phone at any time, 24/7, talk to anyone they wanted to talk to. The patient understood that, and often we went out to see them. Certainly with our dialysis patients, we were there, and that just made an enormous difference.
Can I just speak, I know I've speak too much. Professor Dennis Yu at Auckland South actually, for me, opened my eyes to what I could be as a GP, because he introduced a shared care program for diabetes through Auckland South, but it was incredibly innovative in its time, where we could send our we encouraged us at that point in time to send a patient for an annual review. And he then sent back a full report that he then asked us as the GP to do. He never did anything himself. It was all advised, so it was up to the GP to take the advice on board. But it was an incredibly comprehensive report that went through everything that was important in the diabetic management, went through everything that needed to be reviewed, educated me, so that I became very quickly incredibly comfortable with knowing what it was I needed to do without needing to refer my patients to his clinic. That was fantastic, and that model of care, I think, is what we need to emulate. I know that there's some renal physicians at St George that are doing exactly the same concepts, and it's about sharing the knowledge, sharing the power of saying, it doesn't have to be me who looks after the patient, it's about me showing you how we can do it better together.
Isn't that what consultants are meant to do? They're meant to consult.
But that is entirely where the fee service.
I think the problem with GP money training is
Oh, hello, Aileen.
you know, I think that one of the biggest problems in general practice is to encourage our consultants, our specialists to let go. You know, and it's really an important thing that as a specialist,
Sure.
that they should learn to let go. But in letting go, they need to actually write a comprehensive plan of where exactly they want the patient to be, and communicate with us through, you know, picking up the phone or email or something. And the
The other side, we need to communicate really well as well.
I think you're absolutely right, Brad. I think one of the things that this program has in Liverpool has helped is to actually work with our colleagues so they can actually see that. So it's not just one or two GPs that are actually involved. And the other aspect is that shared system where we all can actually look at what each other.
Yeah.
So I have to say we have found some horrendous things out there that we've had to deal with.
But that's the accountability.
Yeah.
We don't have any accountability here, actually. I don't think. As an individual GP, there's a lot of solo GPs. They're not accountable to anyone, really, at the end of the day, except their patients. And their patients generally, by and large, don't know that they're not getting best care.
I was 10 years on the New South Wales Medical Board, GMC, and I chaired the performance committee. And we'd see lots of complaints eventually coming from patients. They say one patient complains out of 10 who are going to complain, and recurrent complaints around people. And that was the only accountability mechanism. The only accountability mechanism was a complaints-based mechanism. That doesn't seem to me to be modern healthcare, not in any way. We've been talking about quality and safety in healthcare over the last 20 years. Look, I think that might be a good place to finish. some optimism there, things to be done. That's been a very interesting discussion, and always great to hear different perspectives. I must say, John came further than David, but the different perspectives around regional New South Wales and United Kingdom are just as interesting. Thank you all for coming tonight. It's some commitment to come out at night and finish at 7:30. So thank you, and thank the speakers. And if you want to grab a glass of wine